Good evening, fellow nurses. I wanted to do a new video. I have been wanting to do a video for quite some time now. But this video today that I'm about to do right now is going to be on comfort management. I wanted to do a recap on the abdominal assessment, but I will do a recap video to that one. Just give me a little bit of time. I look at doing one within the next few days here. So this video is going to be about comfort management. And I think I did hear this from a tutor, from one of the faculty that I was talking to. And I also, prior to that person talking to me and telling me that, I did kind of get it established that you do need to know exactly what you should document. And that way, if you know what you should document, then you'll also know what you need to do in order to get those values, or to get that subject matter that you're going to be writing about at the end of a PCS. So here, I'll just get right into it. You know, I have baby Julian, my very special patient that I love so much. Say hi, baby Julian. Hi, everybody. So there's baby Julian, and we're going to be doing comfort management today. I do want to just grab like a little towel or something for his comfort. I don't have his very highly specialized hospital bed that I had in one of the other videos. But I do have a couple of comfortable towels for him, and that's what we're going to be using now for his care. So I'm just grabbing those for my laundry area, and we're going to get right to it. So for baby Julian, for the comfort management, I'm kind of just going to make up something as we go along here. I guess we'll pretend like he's got a broken leg for all intents and purposes. And so I fixed him up a nice hospital bed, very highly advanced hospital bed there. As you can see, some beautiful artwork on the walls that my kids did about 20 some odd years ago, so that's nice. But what I want to talk about with comfort management is that the things you need to document, and it looks like if you study all these PCSs and like really read through them and kind of keep going through, you start to become familiar with the fact that a lot of the information is repetitive. So if you take a look at the nursing process, I usually, in my mind, I say ADOPIE: assessment, diagnosis, observation. Hold on, let me see if I can remember. Assessment, diagnosis, observation. What is it? I can't think right now. Anyhow, I want to say, if you take a look at the nursing diagnosis, the only things that we have to do are, we're not doing diagnosis here because the diagnoses have already been provided for us. So what we have to do is we have to prove that we can assess properly, and we have to prove that we can, we have to prove, not approve, but we have to prove that we can properly synthesize the information that we're given. So with that said, I just kind of found that, you know, as a part of the pattern as I started to go through these steps and apply them. And I'm blessed to be a licensed practical nurse at this time, because I can actually, within the scope of my practice, I can actually use these things to assess patients, and, you know, it helps me in the way that I approach my documentation. So whether or not, you know, I'm a registered nurse, still this does help improve your practice, because you now get a chance to be a little more thorough, even within your scope of practice. And I'm very careful to say within your scope of practice, because there's certain things as licensed practical nurse that we cannot do, that is not within our scope of practice. So with that said, I just try to be careful, but also try to be mindful. Like, if I was a registered nurse, what would my decision be? How would I do this? And I also always ask my supervisor, I always ask anybody that I am subordinate to, like, what do I need to do? And I use their diagnosis, or I use their assessment of the situation, because of course that's their scope of practice. They've earned that right, and I have a lot of respect for that. And especially if I, you know, get to that level, or when, I should say, when I get to that level, of course I will want the nurses that, you know, I am charged with being responsible for, I will want them to respect my judgment and my scope of practice. So with that said, I always use initials. Like, I always use the first letter of the words in what I'm trying to use. So I have LCCPCR, like ELCCPCR. You have to document the education that you provide the patient. How are you going to document that? Well, you have to determine what that patient needs to learn. So how you do that is you ask questions. And so we're going to get to some of that with baby Julian today. After you document, the education that you provided, then what's that learner's understanding of that education? So how well were you able to explain this to the patient, and how well were they able to receive it? And if they were able to receive it, then how did they synthesize that information? That helps you, because then you can see, well, where did I lack explanation, or how could I better explain this to them, or how can I better break it down in this person's level of understanding where they're able to give me feedback that is positive for their situation, and that helps move them in the direction of healing, and helps move them in the direction of wellness and maintaining that wellness. So the next thing is, what was their comfort level prior to the nursing interventions that we're going to provide for that patient? What was their comfort level after the nursing interventions? Okay, I'm drawing a blank right now for just a second, but I just need to, I took notes, so I didn't really do that great, apparently, because if I had, then I wouldn't even be looking for this stuff. But I'm just going to look to see what is on this list. So as you can see already, I have not memorized these things perfectly, but I think I'm getting there, and it's been a while since I've done a video, because I do like to be organized, and I've had a lot going on in my life. But I do always want to be helpful to my fellow nurses, and I do appreciate the fact that I have people who have subscribed to this channel, and I want to give you as much information as possible. It helps me as well as it helps you, so I really think that that's a plus for all of us. So again, I think I was wrong when I said, you have to, the education level. So here's what we need to document. I'm just going to recap and fix what I said the first time, which was not correct. So you're going to document the education that you provided the patient. You're going to document the learner understanding. So what did the patient understand out of the education that I provided them? Next, their comfort assessment method. How did I assess that patient's level of comfort? Did I use the Comfort Daisy scale? Did I use the verbal comfort rating? The comfort verbal rating scale, excuse me. Or did I observe their behaviors? And sometimes, you get data about a patient, or you get an assessment about a patient by looking at them when they don't even know that you're looking. So sometimes you have to look at the person, do they have facial grimacing? Are they, hunched over in pain? Are they tense? Are they smiling? Are they relaxed? You can get those things from a patient, especially after you meet them a few times. You get a chance to see, how does that person respond to these things? And especially, always the number one priority is communicating with that person. Like, you have to ask them, what do you prefer? What do you prefer to be called? All those things that go into helping us assess the patient and better understand what their situation is. But after you do the comfort assessment method, you're also going to do the comfort assessment prior to the intervention. So if they tell you, well, my comfort level's at a 2 right now, before we do the nursing intervention, and if we're going to provide them ice or help them, reposition themselves, or get them up and help them go to the bathroom. I mean, a number of things you can do to help the person become comfortable. And then we're going to document that, what comfort interventions, what are their preferences? So even before their comfort interventions, what are their preferences for comfort? Like, what do they prefer? And I usually will ask a patient that by saying, have you ever had this situation happen to you before? Have you ever had this kind of pain? And if they answer me yes, then I'll ask them, well, what do you normally do when you're in this situation? And they can tell me, well, this is what makes me feel better. If they've never had it before, then I tell them, well, we're going to figure out together how to help you. I'll find out what is going on, what the main problem is. And then you can always consult, like, your nursing diagnosis book, which is awesome, gives you a lot of resource. Always helps you. Other nurses will also have resources as well. For the purpose of this exam, we're going to consult our resources, because we need to do that. That's what we're trained to do. That's the end we're working towards. So that's what we always want to do. We don't want to rely on someone else's information that could possibly cost you to fail the exam. You don't want to do that. So I would never encourage anyone to do the wrong thing, because I've done the wrong thing and I know that that hurts. Last two things. You're going to document the comfort interventions that you implemented, and then you're going to reassess comfort after the interventions that you provided. So those are the things. You're going to document 7 items. Education provided, learner understanding of the education that was provided, comfort assessment method, comfort assessment prior to the interventions, patient preferences for their comfort needs, comfort interventions implemented, and reassessment of comfort after the interventions have been implemented. So the first steps that you're going to do within the nursing process would be to assess. You don't have to diagnose anything, but once you do assess them, then you're going to implement the plan of care that you have established. So, you know, what I would do is, come and say, hey, and normally when I come to a patient, hey, baby Julian, on a scale of 1 to 10, and this all depends on what age the person is. Like baby Julian, for the intents and purposes of this, we could say, he's like 2 months old right now. Now, instead of me using comfort verbal rating scale or the comfort daisy scale, I would just observe him and, see is he crying? Is he, how is his cry? Like, is he turning red? Is he able to breathe? Is he, once, a little funny story, I was eating a hamburger and had my son on my lap. And my son, unbeknownst to me, had put his finger in my burger. I don't know why he did this. Still, till this day, he's not able to explain why he did this. But I bit down and I was like, goodness gracious, this thing is tough. It's hard to get this off. I was gnawing. He let out one of those cries where there was no noise for a minute. And, he's sitting right there and I'm like, what is wrong with him? Like, he took a weird breath and I looked down and my baby is, unconsolable, okay? I look and there his little hand is, his little finger was in my burger. And I realized, oh shoot, you just bit him. And I could tell that I tried to get his finger off. Thank goodness there was no broken skin, no bleeding. But at that point I could tell that, he was in a great deal of pain. I say that to say that, you can use your best judgment. Sometimes you look at a little person or even a nonverbal client, they're not able to respond to you in the way that we normally do. Normal everyday assessment of pain, I say to someone, hey, on a scale of 1 to 10, what number would you give the pain? 10 being the worst you've ever had. 1 would mean that almost non-existent, but just a little discomfort. How would you describe this? And sometimes the patient will tell me, hey, I'm at an 8. Again, sometimes I can give them examples like, hey, 10 being, a car accident or I'm going to die, or, like a 5 being, I just got burned with some hot coffee or hot water. You can give them examples as well. I sometimes do that in my own practice. I would say discuss it with your faculty when you do the faculty calls, and I am encouraging you to do that because it's an awesome resource that we have. You do pay for this. This is included with your tuition, and I think it's awesome to have that. So I kind of really don't need baby Julian as the prop right now, so I'll just more talk to you. But when you're assessing, after you've assessed and you determine which comfort scale you're going to use, comfort verbal rating scale, comfort daisy scale, which is good to use for people who don't read well but can show you what face that is associated with their level of pain, and then also observed behaviors. With that, you're going to establish what their preferences are, and like I said, one of those things could be to say, hey, when you have stomach pain, what do you normally do? And a patient will tell you, and a lot of times that is the easiest way to get a resolution for a person for what we're supposed to do. Once you implement, you'll provide education for that patient. Like, are you aware that, if you have tooth pain, honey, if you keep your mouth clean, do proper hygiene, rinsing your mouth, keeping your teeth, brush your teeth after you eat, all of those things can help you to be more comfortable. I'm using, teeth as one example, but there's other examples where you can let them know, like, your skin is going to be more comfortable if you keep it clean and dry. For wounds, that sort of thing. So when you implement, you'll provide education based on what you see the patient needs. Like if they say, well, my, leg is hurting so bad and I just, I don't want to take the bandage off, I'm scared. They'll usually give you a clue as to what they need to be educated on. And that's the awesome thing about being a nurse. 9 times out of 10, the community isn't educated the way that we are, so they don't understand the things that we happen to know. And that's great, because then you get a chance to set an example for them, and then also give them an explanation and give them an education, which is always nice. They're going to be able to teach other people, and they're also going to be able to have this information for themselves. So I'm just moving because I love the change of the light on my face, and I do want to look cute for you guys. So I like to go easy on the eyes. But anyhow, after you implement by doing, you know, interventions, and they have a list of interventions you can use: relaxation, distraction, sometimes, you know, maybe putting a video game on for a kid that loves a video game, even if they're uncomfortable. So a lot of times kids, you know, you find something they love to do, they are on it. Heat or cold are the, you know, time, you know, these are like the hallmark comfort measures that you can do. Like if you offer an ice pack or something, offer a heat pack, that usually really gets somebody to be calm. Adjusting their position, a lot of times if they're scooched down in bed. I've been a patient myself, and you know, my children have been patients over the years, and nurse comes in, helps them go to the bathroom, scoots them up in bed. They're awesome. They're fine. They don't have any complaints. For infants, swaddling them. I always did it with my children when they were little. I think it really helped them a lot. I would swaddle them up real tight, you know, and then depending on where they were at in their level of development or what I was doing, you know, they got a bottle. I don't think my family liked them getting a bottle, but every here and there, you know, they got a bottle instead of the breast, but that was all right. Provide a pacifier for the little one. Provide a comfort object, like, you know, maybe a teddy bear or something. When my kids were little, my son had Taboo. Not baby Julian came years later, but Taboo was his one comfort, that he slept with this thing, took this thing everywhere until he finally lost it. I was heartbroken, I think, more than he was. He was old enough to like let it go, but I really wasn't, and I was just devastated when he lost this teddy bear. Like, it was dirty, it was probably ready to go, there was holes all in it and everything, and I wanted it for him, but it was like, okay, let it go, Mom. Other interventions that are consistent with the patient's current clinical conditions. There's other things you can do. I mean, you can prop up a leg, you can give them an extra pillow. There's simple things you can do, and there's a lot of things that are listed in our nursing diagnosis handbook. So that's at some point, you know, in one of these videos, I'll get out the nursing diagnosis handbook and go through that. To evaluate them, you're gonna find out, you know, you ask them questions or have them repeat what you said to them about, you know, how to keep themselves comfortable. So next time, you know, you have this issue, what are you going to do, Johnny? Or what are you going to do, baby Julian? And then he's going to explain to you. And hopefully, you know, he repeats back the things that you've educated him on. And I'm saying hopefully because sometimes patients don't always do what we want them to do, right? But for the purposes of this exam, most assuredly, they're going to repeat back what, you know, the education that you've provided, because you've been that good at educating the patient. And then you're going to reassess their comfort level. So you reassess it using the same same assessment method that you used in the beginning, because that would always be appropriate for this patient, right? And then you're going to do the documentation using those 7 steps that we discussed in the beginning of the video. As far as comfort management, I think it's pretty self-explanatory. I think if you practice it enough, you'll kind of get there with it. I have been using these in my documentation. My notes are long as all get out. I know I sometimes get on the other nurses' nerves because the notes are like so long, and they're like, why'd you write a novel? But it's like, well, I actually wrote this novel because I'm practicing and I need to be, you know, I need to be thorough with these notes. So I'm really pleased with it. It is a lot of work. In the future, I'm sure it will be a little more truncated, depending. But I do sometimes grab like one of these areas of patient care, and then I will like document on it like there's nobody's business. So, you know, I've appreciated being able to use this in my current practice, and I would like to do more videos. So what I'm going to do is I'm going to end this video here, and if you have any questions or comments, be sure to leave them down below. I do appreciate your support, and I do appreciate you watching my video. As always, I love you all, and I do wish us all success in this journey. Thank you, and have a great night.